Bismillahirrahmanirrahim. My name is Dr. Fawad Jan, Assistant Professor Neurology. Today we are going to discuss multiple sclerosis, the objectives of this lecture. At the end of this lecture, the final year student will be able to define multiple sclerosis, discuss its epidemiology, its etiology briefly, its clinical features in detail, name its differential diagnosis, will be able to enumerate investigations, discuss basic findings in these investigations. We'll be able to enumerate the different treatment options, their indications, contraindications, adverse effects, and monitoring strategies, these treatment options, and we'll be able to discuss its prognosis briefly. Definition of multiple sclerosis. It is an immune-mediated disease in which the body immune system mistakenly attacks myelin in the central nervous system. So there are 4 points. It is autoimmune. Second point is it affects the central nervous system. The peripheral nervous system is spared. The third is it affects the white matter. The gray matter is spared. The fourth is it affects myelin while the axons are spared. Epidemiology. Epidemiology of multiple sclerosis. First is age. In this graph, as we can see that most of multiple sclerosis patients present between 20 and 40 years of age, while is rare below 20 years of age. Also, above 50 years, multiple sclerosis patients are very rare. So typically, the onset is between 20 and 40 years. Peak age of onset is the fourth decade. Females, it is 5 years earlier. Mean age of onset in relapsing form is 30 years, while in primary progressive form is 40 years. It is a unimodal age-specific onset disease. The peak only occurs once, while in essential tremor, there another peak, usually in the fourth decade. One is in the second decade, and another one is in the fourth decade. Onset before puberty and after 60 is rare, but 5% of cases occurs before puberty, most in adolescents, only 0.3 to 0.4% in the first decade in childhood, 3 to 12% after age 60. Gender, more females are affected than males. This is in accordance with most of the autoimmune conditions, but the underlying cause is unclear. Female to male ratio is 2:3 in relapsing, remitting form, while in primary progressive, it is 1:1. Male to female ratio is equal. Geographical and racial distribution is very low equatorial areas, while in both temperate, colder areas, temperate zones of both hemispheres is high. In the rural areas, it is 1 per 100,000. As you can see, India, Pakistan, China, while Northern Europe, it is 100,000 in these areas. Another risk factor is the race, population of white extraction, especially in European being more susceptible, while Asian, African, and Native Americans are the least affected ones. Etiology of multiple sclerosis. The main etiological factors are autoimmunity, genetic susceptibility, and environmental factors. Autoimmunity. Multiple sclerosis is basically a T cell mediated autoimmune disease, but there is some moral autoimmune involvement as well. There are antibodies found against myelin basic proteins as suggested by oligoclonal bands CSF. The immune hypothesis is supported by within CSF increase activated T lymphocytes and increase immunoglobulin synthesis. Genetic susceptibility is supported by race and ethnicity as the disease is more prevalent in some ethnic groups as compared to other. It is more in northern European ancestry as compared to others at the same altitude like Asian, African, or Native Americans because they have lowest risk even if they're living in US or UK, likely to be due to genetic differences. There is also familial aggregation. Risk of familial occurrence is 15%. degree of heritability by comparing risk in half sibling versus full sibling. What is half sibling? Sibling. One biological parent versus two in common. If two of the biological parents are affected, then the risk is 2 to 3 times greater as compared to if one biological parent is affected, which is for half sibling. This suggests non-Mendelian inheritance. Twin studies also suggest increased susceptibility. It is the 30% of monozygotic twins are affected as compared to 5% of dizygotic twins. The genes are incompletely defined, appears to be polygenic. Some 60 different genes have been identified. 80% are related to system function and regulation. The most important are major histocompatibility, complex polymorphism, human leukocyte antigen typing, and interleukin receptors. Environmental factors. These include infection, vitamin D and sun exposure deficiency, smoking, infection. The pathogens which are considered to be triggers are human herpes virus 6, Epstein-Barr virus, and chlamydia pneumoniae. Epstein-Barr virus is suggested by very high prevalence amongst the multiple sclerosis patient, which is between 90 to 95% in some studies as compared to greater than 95% in others, but it is definitely not 100%. And the mechanism by which it causes increased MS risk is by autoreactivity. It causes immune response by attacking some components of myelin, and that also because of similarity between their molecular components. This is supported by similarity of lesions to acute demyelinating encephalomyelitis, which is a established autoimmune delayed hypersensitivity type of disease. Antibodies to specific myelin protein, myelin basic protein. These are found in both the serum and CSF MS patients, and they are reactive to myelin basic protein and to other myelin proteolipids. These increase with disease activity, and the myelin basic protein cross-react with the measles virus antibodies as well. The other mechanism by which Epstein-Barr virus can cause increased MS risk is by directly promoting persistent inflammation in central nervous system. The role of vitamin D and sun exposure is another area of epidemiological research. Lack of exposure to these two is suggested by some studies. This by some suggest that this explains the latitudinally graded risk. Gastrointestinal microfloral communities in MS is suggested by some other studies. Cigarette smoking is also associated with increased MS risk. How all these environmental factors contribute to MS pathogenesis remains to be interpreted. Clinical presentation. Symptoms in multiple sclerosis. These are pathologic manifestations. Patient will be paraplegic. There will be weakness in both lower limbs. Cervical cord, or then there will be weakness in all four limbs, which is called quadriplegia. The weakness can be partial, in which patient can walk with support, or can be complete, which the patient will require wheelchair. Neurological examination, the power will be reduced. There will be hyperreflexia when examining deep tendon reflexes. The extensor plantar response will be there. We check for clonus. There will be well sustained clonus. As the spinal cord, there is involvement of dorsal medial meniscus system as well. There will be loss of position as well as vibration sense. There will be usually, if the thoracic cord is involved, there will be a sensory level. If there is demyelination in the cervical area, then there will be Lhermitte sign, in which on sudden session of electric shock is felt when patient flexes his neck. There will be fecal incontinence or constipation, urinary hesitancy, frequency, genic bladder. So spinal cord involvement. Sensory symptoms are tingling, numbness, burning, tight bands, altered temperature sensation, and dermatitis symptoms. Motor symptoms will be weakness, heaviness, clumsiness, sphincter, urinary deficiency, incontinence, hesitancy. constipation or fecal incontinence, impotency. If the optic nerve is involved, then there will be sudden loss of vision in one eye, which can be partial or complete. There will be movement, there will be pain on movement of eye. When later on, after a few weeks, on ophthalmoscopic examination, there will be failure of the optic disc, which is called optic atrophy. Usually, the patient visual symptoms recovered after 2 to 3 weeks. Sometimes, visual field examination, there is only central scotoma. If optic nerve head is involved, then there will be papillitis, in which case there will be optic nerve head swelling, which will be just similar to edema on fundoscopic examination. While if there is retrobulbar neuritis, the optic nerve is involved behind the eye, then there will be relative and pupillary defect, in which when we move a light source towards the affected eye, instead of constricting, is dilate. It means that the optic nerve is affected on the side. Brainstem or cerebellar symptom. Sometimes demyelination, supraocular controlled fibers of extraocular movement occurs in multiple sclerosis. Medial longitudinal fasciculus demyelination occurs, and there is internuclear ophthalmoplegia, in which on the side of uh, involvement, the patient fails to conduct the eye while the other eye abducts and there is nystagmus. As in this case, the patient fails to adduct the eye when looking towards the left side, while the left eye moves away, ducts, and there is nystagmus in it as well. When the patient tries to look towards the right side, there is again adduction, nystagmus in the right eye, slight adduction paralysis in the left eye. On looking at a close object in front of the conversions is fully preserved. This is because of demyelination of fasciculus, which connects the nuclei of third and sixth nerve with each other. This patient, the cerebellum, wormus, or both of the hemispheres or cerebellar peduncle involvement can lead to such a presentation in which there is wide base gait, there is truncal swing towards one or the other side. Finger nose test is impaired in such patient. The heel shin test is also impaired. There is hyperreflexia. There is intention tremor while performing task. This is because of involvement of cerebellar or middle cerebellar peduncle, or the involvement of cerebellar wormus or the cerebellar spheres. Sometimes the internal capsule area involvement can occur, which present is aminopia can occur. Sometimes there is involvement of the going towards the occipital cortex. Dysphasia, seizures, and cognitive impairment are rare manifestations. Frequency of symptoms at disease onset. Sensory disturbance is a major symptom presentation at onset. 34% of patient present sensory disturbance, 22% with weakness, monoparesis, hemiparesis, paraplegia, sometimes quadriplegia, visual loss in 13% of cases, axia diplopia due to involvement of the brainstem interconnector connecting fibers between the nuclei of the extraocular muscles. Vertigo due to involvement of the cerebellum, vestibular apparatus and its connections. Frequency of symptoms during the entire disease course. Weakness is present in 69% of cases. Sensory disturbance in 87, ataxia in 82, bladder disturbance in 71, fatigue in 57, cramps in 52, diplopia in 51, visual loss in 49, bowel dysfunction in 42, dysarthria in 37, vertigo in 36, facial pain like trigeminal neuralgia, 35, but memory dysfunction, headache, psychiatric symptoms, hearing loss, facial weakness, dysphagia, pressure sores, loss of consciousness, and loss of taste. We encounter these early on, then we should think of some other diagnosis instead of multiple sclerosis. Investigation. So exclude other structural diseases and identify flags of demyelination. Neuroimaging of whole neuroaxis is recommendation. The neuroimaging we perform with contrast. Sometimes for demonstration, the sites of visual potentials, so somatosensory potentials. CSF is rarely performed. We get oligoclonal bands on green electrolysis, and for the exclusion of other conditions which mimic multiple sclerosis, like chest X-ray for sarcoidosis and Church-Strauss syndrome, AC levels for sarcoidosis, levels, vitamin B level deficiency also, and sometimes present with subacute depression of the cord, which there is also position and depression sense in the lower limbs. The powers NA levels to exclude systemic lupus erythematosus antiphospholipid antibodies in the highly specific findings of the periclosal hyperintensities, which are perpendicular to the they are find sagittal section of him as in COA. They are highly specific for multiple sclerosis. In the sometime in the periventricular area, there are many hyperintensities occur in other conditions. One of the common one, atherosclerosis, ischemic vascular disease of brain, which many microinfarcts occur in the brain, the periventricular area. So if more than 50 years of age patient you see these kind of hyperintensities and hypertensive and diabetic, so it would be difficult to differentiate whether that patient is a multiple sclerosis patient or he has got multiple causes due to atherosclerosis. So the characteristic areas multiple sclerosis are periventricular, cortical or juxtacortical neocortex, the U fibers, infratentorial in the spinal cord or cerebellum, and spinal cord, the white matter. And if there are lesions, 2 or 3 lesions, some are contrast enhanced, the other are not taking contrast. It means that those which are taking contrast are youth, while those which are not taking contrast are the older one, 4 to 6 week old. So single MRI with contrast will sometimes help in fulfilling one of the criteria, dissemination in time. CSF examination. The CSF in there will be is gamma globulin, which are oligoclonal bands. They are basically antibodies against myelin basic proteins, which are large quantities against the myelin. But these oligoclonal bands are not very specific for multiple sclerosis, as these can be found in tuberculosis, subacute sclerosing parenchyphalitis. So, although they are very sensitive, they are present in 85 to 90% specific. 85 to 95% you go PG. By normal controls, only percent you will get. Evoke potentials. There are three kind of evoke potentials. One visual evoke potential, the brainstem vibratory evoke potentials, and the third one is somatosensory evoke potentials. These are responses which are obtained. These are responses which are obtained by stimulating the pathway which carry the visual stimulus, and they are recorded from the visual cortex, occipital cortex area. In this, you can see that there is a checkerboard pattern changes with time. This flickering, changing pattern stimulate eye. These impulses are then taken by the optic nerve to brain, occipital cortex, and from there they are recorded. These are two patients showing graph visual evoke responses. In one, there is a absent visual evoked response on the right side, when there is a delayed response. See in this graph, the patient with somatosensory evoked potential, in which the median nerve is stimulated at the wrist. The recording is done at supraclavicular area at the spinous processes C2 and at the contralateral lateral area. So these are the responses we get in the contralateral occipital cortex if there is demyelination in the tracts, dorsal column, medial meniscus system, then there will be delayed response, which will be obtained cortex comparison of sensitivity of the different tests. Most sensitive is MRI, 7%. Oligoneuronal bands is 85 to 95%. Somatosensory evoked potentials. The fourth one, the third one is visual evoked response, 82%. Brainstem auditory evoked responses are rarely performed. Disease course. In this graph, as you can see that there are four types. One is fulminant, very rapidly progressive, and other is relapsing remitting form, which is in 80% of patients. Third type is primary progressive, which is in 10 to 20% of patients, is shown by the red line. The fourth type is secondary progressive, in which 80% of the relapsing remitting form patient after 35 years takes the course of secondary progressive form. As you can see, this form relapsing remitting in 90%, secondary progressive phase in 75% of relapsing remitting sclerosis after few years of relapsing remittance, primary progressive in 10 to 15% of sclerosis patients. Diagnosis, as there is not a single test for multiple sclerosis, there are clinical features with dry, supportive CSF evoke responses. So it is an other diagnosis but excluded by investigation. This kind of disease is usually required diagnostic criteria. The diagnostic criteria for multiple sclerosis is McDonald criteria, which is revised in 2017 by the International Panel criteria. It is not important to remember person, no name, and some of the important like two or more relapses, objective clinical evidence of two lesions. This is relapses, new neurological manifestation with objective evidence that the causative lesion is demyelinating in nature, and that neurological manifestation is for at least 24 hours. Treatment of multiple sclerosis. It includes three different approaches. One is treatment of acute episode, other is prevention of future relapses, third is treatment of symptoms, complications, and disability. So, acute relapses, these are treated by short courses of steroids, which are usually IV methylprednisolone 1 gram per day, 3 days. Sometimes high-dose oral steroids. These are used for severe relapses in which there is motor weakness. They speed recovery, but they are not beneficial in long-term outcome. Sometimes there is rebound disease activity after stopping glucocorticoid treatment. So high-dose IV steroids are followed by oral taper prednisolone 10 to 15 days. Disease-modifying treatments. These does not totally cure the disease. These are given to prevent relapses. They reduce disability and reduce the number of relapses, and as well as reduce the number of lesions in the MRI. So the drugs which are available are first line drugs are those which are moderately effective but are having less side effects. These include interferon beta, glatiramer acetate, teriflunomide, and dimethylfumarate. The second line treatment drugs are those which are highly effective. They have got severe side effects, and these are given for These are given to those patients which do not respond to these are given to those patients which do not respond to the first line drugs, or the disease course is very aggressive over time. Patient does not respond to second line, then we go to experimental drugs. The drugs which I enumerate in the previous slides are these slide. The mode of action of those drugs are given beta interferon immunomodulatory. The mechanism of action of glutamate acetate is while natalizumab and alemtuzumab monoclonal antibody, which suppress white blood cells. Volimod, oral disease-modifying drug. It is a sphingosine 1-phosphate receptor ligand. It prevents T cells leaving lymph node. The mechanism of it is unknown. Teriflunomide blocks proliferation of related lymphocytes. Disease-modifying drugs are divided into moderately effective versus high effective. Effective drugs reduce average relapse rate by 30 to 50%, while the highly effective reduces average relapse rate by greater than 50%. Moderately effective drugs are beta, glutamate acetate, teriflunomide, dimethyl fumarate, fingolimod, while the highly efficacy drugs are alemtuzumab and natalizumab. There's another drug which is recently approved by the FDA. It is ocrelizumab. It is also a monoclonal antibody. It is also available in Pakistan. It is FDA approved for both relapsing remitting kind of multiple sclerosis as well as for primary progressive multiple sclerosis. It reduces annualized relapse rate by 46%, reduction of disability by 33%. Side effects of multiple sclerosis and their monitoring strategies. Interferon beta gives flu-like symptoms, elevated cardiac enzymes, leukopenia, headache, depression, skin necrosis, reactions. Of flu-like symptoms are treated with NSAIDs and nutrition. Elevated hepatic enzymes, we usually do baseline and monitoring blood pressure. Patient are observed for headache and depression. Sometimes patient develop antibodies against the beta, so antibodies should be checked regularly. If they're produced, then patients should be switched over another therapy. Glutamate acetate develops skin reactions and immediate post-injection systemic reaction, chest tightness, flushing, tachycardia, which the patient requires counseling. Eculizumab is another injectable. The side effects are sensitivity reactions, severe injury, immune-mediated disorders. Hepatic monitoring is usually done regularly for these patients. Infusion drugs include natalizumab. Allergic reaction requires monitoring. There is risk of progressive multifocal leukoencephalopathy, because of which once it was taken out market, and but then again it proved to be used for multiple sclerosis patient. JCV antibody testing should be done every 6 months. The titers are greater than 1.5, and the fusion be given after every 2 years. LM sumab, autoimmune events, hyperthyroidism, immune thrombocytopenia, immune glomerulonephritis, skin cancer, fusion reaction, and severe viral infections. Monthly blood picture and blood stimulating hormone is checked every 3 months. Skin check for skin cancer and prophylaxis before infusion for infusion action. Viral prophylaxis for severe viral infections. Mitosintron, another disease modifying drug which is given the infusion, causes cardiomyopathy and ischemia. Cardiac monitor, left pulmonary ejection fraction, wide baseline and monitoring red blood count. Ocrelizumab causes infusion reaction, reactivation of that is virus infection, opportunistic infection, potential. HBV testing should be done for infection. The oral drugs include fingolimod, dimethyl fumarate, and teriflunomide. The side effects are cardiac events on first dose, herpes infection, macular edema, cardiac enzyme derangements, openia, progressive multifocal leukoencephalopathy. For baseline ECG, be done monitoring first dose, cardiac consultation if ECG is abnormal, Varicella zoster virus serology screen is required, vaccination if the VZV screen is negative, baseline and 3 month eye evaluation, baseline and 3 month FTs, and with blood count, clinical monitoring. Dimethyl fumarate causes lymphopenia, flushing, gastrointestinal symptoms, aggressive multifocal leukoencephalopathy, complete blood count at baseline every 3. Teriflunomide causes teratogenesis, hepatic dysfunction, deactivation of latent causes alopecia. Baseline and every 6 months electives are required. Contraception should be ensured. Screening for tuberculosis, all these are required in teriflunomide. So another chart in which the drugs are given the order of feasibility. Feasible is to give them in time. Like daclizumab is given as an injectable which is per month subcutaneously, while interferon beta will be given once every 2 weeks. Nox is a muscular interferon beta which is given once weekly. Rebif is another brand of interferon beta which is given 3 times weekly. Copexone, these three are Glutamate acetate, different brands which are given daily or 3 times weekly. Beta seron and steva, these are interferon beta 1b, which are given every other day. These are intravenous infusion, which are usually given at hospital or infusion center. Lemtizumab is given once a year. Mitozentron every 3 months. Ocrelizumab 6 months. Natalizumab 4 weeks every month. Teriflunomide oral tablet, which is given once daily. Fingolimod is a capsule which is taken daily orally. Dimethyl fumarate, the form of tablet which is given. So all these drugs, interferon beta, glutamate acetate, dimethyl fumarate, and teriflunomide, first-line drugs in European Union as well as in US, while Volimod second line in European Union, while first line in US. Natalizumab, second line drug. Centron is third line, or rarely used, of complications in sclerosis, spasticity, restone requires self-management including stretching, physiotherapy, and venting, skeletal muscle relaxants, the form of baclofen, zanidine, benzodiazepines, botulinum toxin injection, focal spasticity, cortical baclofen pump, severe cases, pain, requires pregabalin, gabapentin, carbamazepine, diminutive straight dysphenomen, straight with carbamazepine require antidepressant and cognitive behavioral therapy. Impaired mobility requires physiotherapy, walking aids, treat spasticity, iodine, which increased action potential conduction, nerve fibers, urinary symptoms, spastic bladder, oxybutynin, tolterodine, sulfanicin, and trospium. There is flaccid bladder, intermittent self-catheterization is performed. Botulinum toxin type A injection can be used for spastic bladder. Relax it, leak, treated with tridine, modafinil, trimmer, beta blockers, botulinum toxin injection, and deep brain stimulation for severe tremor. Prognosis: disease is less severe in females. It has got favorable prognosis younger age group as compared to later age. Onset at earlier age has got better prognosis as compared to later age. Relapsing remitting multiple sclerosis better prognosis than primary progressive and secondary progressive multiple sclerosis. A higher rate of relapses early in the disease, short first interval between attacks leads to shorter time to reach higher disability, which is measured by extended disability status scale at point 6. Patient is not able to walk independently. Initial manifestation. The patient initially has got sensory symptoms or optic nerve vision has got favorable prognosis if there is motor weakness, pyramidal tricks are involved, or there is brain stem or cerebellum involvement, then it has got poor prognosis. Patients with mild disease 5 years after diagnosis only uncommonly severe disease by 10 years and 15 years. Life expectancy is reduced by 7 years on average. These are the references. Thank you for listening.